And it's a difficult task we have here. Imagine how many people who come to our clinic with cough in the winter time. Sometimes we send them to an X-ray. I see some of you are writing. You can have all my slides just by sending me an email. No problem. You'll be very welcome to have all my slides by sending me an email, and my email address is here. We send some people to an X-ray of their chest. For every time we send 200 people to an X-ray of the chest, some 4 will have suspicion of serious cancer, 1 will have his cancer. How does that machine work? Or to put it in another way, this is an Australian piece of work. If you have a population of 2,000 people on your list, some up to 600, more than 600 would have had rectal bleeding at some time in their lifetime. Nearly 400 would have had it within the past year. And of these, more than 40 would have had a bleeding from their rectum for the first time within the past year. But only some 15 to 30 of them attend the general practitioner. Try to imagine what a huge, well-functioning filter machine who works outside general practice. But how do we influence that filter machine? Try to imagine what would happen if people did as we tell them to do, run to your DP as soon as you see blood in your stool. It would be difficult. And one of them will have a bowel cancer. And it is a disaster if we as frontline physicians fail in diagnosing that one bowel cancer in due time, provided that they have attended the healthcare system. It tells a little bit about the difficulties in dealing with the serious diseases, and it keeps asking me, how can I make quality initiatives that focus on this part of the general practitioner's work? To put it in another way, do I have any impact on when they interpret a feeling like first symptom? Do I have any impact on when they come to the doctor for the first time? Do I have any impact on the diagnostic trajectory or on their position within the healthcare system? To put it short, do I have any impact on patient delay? Yes, we have, and I'll come back to that. Of course, I have on doctor delay in the sense that I should begin to reflect on serious disease. But I also do have some impact on the trajectory from I've begun to think of a serious disease until the serious disease is diagnosed. And how does that work in a modern healthcare system, in a managed system like the Danish one? How is the diagnostic delay? This slide shows a group of cancer patients. One have waited 0 and one have waited very, very long time, and they are all together some 1,400 cancer patients. And what you see here is that a quarter of all cancer patients, the red ones, they had 2 or 3 years ago at least in Denmark, they had, now we have changed it quite a lot, that's not the issue of today, they had a more than 3 months pathway from they showed up with the healthcare system, from their doctor began to think that it might be serious until we began to treat. Is that quality or isn't it quality? And what is the DP responsibility in these issues is the question to be raised. So when I should in some way sum up on this first part of the red part of my slide, I keep asking myself if it is an old-fashioned thinking that we think of primary care and secondary care. Is that an old building that is about to break down? In many ways, I think so. We should develop systems that work on the total trajectory, and we have a main responsibility for that part of it. We should remember in quality work to focus on integration during all the diagnostic process and in the treatment phase. And in Denmark, we are currently taking the consequences of this insight and trying to rearrange our access to diagnostic investigations in a 3-bullet way. First bullet is that we try to improve the front line's access to high-tech and high-quality diagnostic imaging and endoscopy and so on and so on. We, as the British also have done, have made fast tracks for obvious disease, whether it's heart disease or cancer. And we are about to take the consequence and rebuild small hospitals. No, we don't rebuild small hospitals. But as we have concentrated our hospitals to a very few and very concentrated hospitals, we try to establish within a few of these hospitals something that we call secondary care diagnostic centers. The center where we as frontline providers can send the patient and say, help me, I have no idea what it's all about, but I know for sure that he is diseased or sick. Earlier on, a few years ago, we closed our eyes and said, well, the biggest chance is to send him to silo number A. And we failed. Silo number A gave a measure back. No, this is not a renal problem. And the patient came back, and we sent them to the silo number B. It may be a rheumatology problem. No, silo number B, and etc. I think you see the same tendencies in most healthcare systems. We have to find ways to deal with problems we have in frontline, and we should ask for that when we collaborate with the healthcare providers. And we should try to develop in different ways in Europe ways of collaborating with the specialized care out near where patients live. I'm sure in future we'll see some sort of specialized satellites working very close to us in different settings, in different places in Europe. I don't know how it should be. Let's look at the next part of the red spot. That's access to us. Access is a quality issue that we should address in general practice. Access to us, do we have any impact on that? At least we know, and we've seen it, all of us, again, a slide, how long is the patient delay? Do they come in due time? And again, a quarter of patients wait very long time. Is that the responsibility of a general practitioner? Is that an issue for quality thinking in general practice? Or is it just that some people are more clever than other people? My main point is that we should address accessibility and whether we are good in accessibility as a quality issue when we address quality in general practice. This is from a thesis recently published from our department by an anthropologist who had interviews with a lot of patients who had delay in their access to healthcare. And she said, it can be divided into 3 main topics. My perception on access to the healthcare organization. I mean, it doesn't matter how the access is in reality. What matters is my perception of the access to the healthcare system. That's one of it, she said. Then it is my personal experiences with symptoms. What should I react on? What shouldn't I react on? And this addresses the question in general practice. Dear general practitioner, never let a patient leave the consultation without being sure that she or he learned something today. But what did we teach them? What did we teach them over a long continuity of care contact with respect to symptom interpretation, with respect to how open our doors are, with respect to how many symptoms they are allowed to come to in our country? In this country we have had, I think it's stopped now, a disastrous development where some GPs said that you could only come with 1 symptom. I mean, this is insane. You can only come with 1 symptom. People have a lot of symptoms, and it's our job to interpret them. So symptom experiences, can we have impact on that? Yes, we can. And we can also have impact on how the social network reacts in relation to symptoms. And I think we should address this much more. And I'll give you a couple of examples on that. She asked why patients didn't come to the GP in due time. Instead of sending me to the hospital, he just started giving me the pills. You know, that was no good. I lost trust in him. It's an enormous power to be a gatekeeper. Are we aware of that? And do we abuse or use our power in a wrong way? It's a question that should be addressed. I don't know if it's a relevant question. Yes, I know it's a relevant question, but I don't know the answer of the question. He's only sent me to a specialist once, so I stopped talking to him about specialists because I got the feeling that it was stupid. There is some sort of an asymmetrical relationship. Are we aware of that, and do we deal with that in an active way, and do we address it from a quality point of view? Most countries in Europe are going in the direction of a list-based system, patient list with a GP, and I think it's a good thing. But I don't want to bother my very good old GP too much because he's so busy. When we leave the university as young doctors, we decide whether we are busy or not. It's a decision, and we want to have this image of being busy. But what is the impact of the perceived perception, and how can we modify this if it can be modified? I do not want him to think I'm a hypochondriac. What a word. I mean, this is one of the biggest welfare goods in our society, that you can attend a GP with whatever symptom you have, and you shouldn't never be labeled by coming with a symptom. But some people don't want to come because they are afraid of being labeled. Do we participate in that stuff, or don't we? And how can we address that from a quality point of view?